Diabetic Ketoacidosis, also known as DKA, by Tristan Barrios and Chelsea Bojorquez. What is DKA? DKA is a complication of diabetes that can be life-threatening. As of 2015, approximately 30 million people in the United States had diabetes. This condition develops when the body can't produce enough insulin. Therefore, the body begins to break down fat as fuel. This process produces a buildup of acids in the bloodstream called ketones, eventually leading to diabetic ketoacidosis if left untreated. It is important to remember that DKA is characterized by uncontrolled hyperglycemia, metabolic acidosis, and increased production of ketones. While DKA can occur in both type 1 and type 2 diabetes, it is more common in type 1. Most often, it occurs in type 2 when people are under severe stress, such as infection or trauma. How does someone get diabetes, therefore becoming susceptible to DKA? There are modifiable and non-modifiable factors. Modifiable factors include things such as diet control, exercise, hypertension control, avoiding alcohol, and avoiding smoking. Non-modifiable risks include age, family history, previous cardiac events, and type 1 diabetes. The most common precipitating factor of DKA is infection. How do we diagnose DKA? A complete blood count will be done, with WBC count being a sign of dehydration. ABGs will also be done with a pH under 7.3. Glucose over 300. Bicarb levels under 18. Urinalysis with ketones in the urine, a BUN over 30, serum electrolyte panel, an anion gap over 10, and a chest X-ray. Signs and symptoms of DKA include decreased alertness, deep, rapid breathing, often known as Kussmaul's respirations, dehydration, dry mouth and skin, flushed face, a fruity smelling breath, headache, muscle stiffness or aches, nausea, vomiting, and stomach pain. The priority treatment for those in DKA is fluid replenishment. We want to replace the fluid lost through excessive urination as well as help dilute the excess sugars in the blood. This is done with an initial infusion rate of 15 to 20 milliliters per kilogram per hour of 0.9 normal saline for the first hour. Once the blood glucose reaches 250 milligrams per deciliter, 5% dextrose in 0.45 normal saline, also known as sodium chloride, is given to prevent hypoglycemia and cerebral edema. This only takes place once the blood glucose reaches 250 milligrams per deciliter or lower. We want to monitor for signs and symptoms of CHF and pulmonary edema. Next, we want to focus on electrolyte replacement. This is received to keep the heart muscles and nerve cells functioning normally. It is important to monitor for signs and symptoms of hyperkalemia or hypokalemia, as the therapy may interfere with the potassium channel's natural way of working. Insulin therapy reverses DKA. IV therapy is the initial treatment to give insulin. IV therapy is stopped when blood sugar falls to about 200 and blood sugar is no longer acidic. Once that takes place, patients can resume sub-Q insulin. The IV treatment for DKA is an initial bolus of 0.1 units of regular insulin per kilogram, followed by continuous IV infusion of regular insulin prepared in 0.9 normal saline, also known as sodium chloride. A hypotonic saline solution can also be used at a rate of 0.1 units per kilogram per hour. The goal is to lower serum glucose by about 50 to 75 milligrams per deciliter per hour. Here is a helpful slide to visually demonstrate the management of DKA. How can we prevent DKA from occurring? Well, there are several risk factors to consider, such as infection being the primary risk factor. Examples of this include pneumonia, UTI, sepsis. Other risk factors include not being compliant with insulin for type 1 or type 2 diabetes, smoking, heart attack, recent stroke, pregnancy, surgery, and trauma. It is important to partake in a diabetic diet, eating 3 meals a day at regular times. It is important to include fruits and veggies, whole grains, poultry, fish, nuts, and fiber in this diet. Examples of fiber include lentils, beans, avocado, fruits, and legumes. It is important to teach patients not to smoke, to participate in a healthy, balanced diet, as the body can go into starvation mode. It is important for them to control stress, manage diabetes, and participate in glucose checks, especially if they are sick. It is important to stress insulin compliance, an active, healthy lifestyle, a healthy diet, and provide them with stress control techniques. It is important for the patient to seek medical help ASAP if their glucometer reads too high or too low. Here are some helpful questions to assist in taking in this information. Which of the following statements are incorrect about diabetic ketoacidosis? A. Extreme hyperglycemia that presents with blood glucose over 600. B. Ketones are present in the urine. C. Metabolic acidosis is present with Kussmaul breathing. D. Potassium levels should be at least 3.3 or higher during treatment of DKA with insulin therapy. And the answer is A. Extreme hyperglycemia that presents with blood glucose over 600. Extreme hyperglycemia that presents with blood glucose over 600 is present only in hyperglycemic hyperosmolar non-ketoic syndrome, also known as HHS. The other answers represent DKA. As mentioned earlier, blood glucose is over 300, but under 600 with DKA. Diabetic ketoacidosis is characterized by, select all that apply. A. Uncontrolled hyperglycemia. B. Metabolic acidosis. C. Increased production of ketones. D. Serum pH over 7.4. Do 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 do. The answer is A. Uncontrolled hyperglycemia. B. Metabolic acidosis. And C. Increased production of ketones. It is important to remember that with DKA, the pH is under 7.3. The patient will present as acidotic. With HHS, the pH is over 7.4, but this is not a characteristic of DKA. Regardless of all that, the pH is not a factor that characterizes DKA. The priority intervention for someone experiencing diabetic ketoacidosis is A. give 5% dextrose in 0.45 sodium chloride, also known as normal saline. B. Restore volume and maintain perfusion to the brain, heart, and kidneys. C. Administer insulin sub-Q. D. Call the rapid response team. Do 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 do. The answer is B. Restore volume and maintain perfusion to the brain, heart, and kidneys. The priority intervention is fluid replenishment. The typical infusion rate for DKA is 0.9% sodium chloride at 15 to 20 milliliters per kilogram per hour during the first hour. It is important to remember that fluid replenishment does not change until the blood glucose is 250 or less. This will be the IV therapy you provide in the first hour in order to replace fluids, which is the priority intervention for a patient in DKA. Here are the references for this PowerPoint. Thank you for watching.